Good afternoon. First of all, I would like to show my appreciation to the organizing committee of the 15th Biennial Convention of the ASEAN Neurological Association 2023 for their gracious invitation to speak to me in this convention. And also, I'm honored to speak along with Dr. Chang, Dr. Navarro, Dr. Ramani, who are well-known stroke neurologists in the regions. I'm deeply honored on that. So why infection is important in the cause of the stroke? So you already know that the stroke is the leading cause of death and the disability worldwide. And 80% of the strokes occur in the low country and the middle income country. At the same time, infection is a major public health problem in these countries. So the proportion of infection-related strokes is possibly greater in these countries, in these areas, including ours. The association between the infection and the stroke is bidirectional. The infection can lead to stroke, and the stroke can also induce the immunosuppression, leading to the chronic risk of infection. And especially true in the last 2 decades that we do have rising numbers of HIV infection, as well as immunocompromised patients due to the organ transplantation, as well as use of the immunosuppressant drugs. But for a few studies have been focused on the direct infectious cause of the acute stroke. So nobody knows the exact pathogenic mechanism of the infection-related stroke. Everything is an assumed pathogenic mechanism. So they think that one is a direct invasion of the arterial wall endotheliopathy. Second one is acceleration of the atherosclerosis induction in cytokines in response to the specific antigenic stimulus, and the acute systemic infection as a stroke trigger, and the chronic inflammation due to multiple infection, which is also known as a burden of stroke, infectious burden. And when you look at the selected studies in these, on the right-hand side, you can see the farmer's right-hand side, you can see the percentage of the ischemic stroke in the setting of the known infectious illnesses. It is ranged anywhere from the 1% to 25%. So what is the infectious burden? Infectious burden is the exposure of the increasing number of pathogens that could have a cumulative effect that leads to increased progression of the carotid and the cerebral atherosclerosis, increased chloric blood thickness, and a cognitive decline in the domains of the executive functions and the memory. This is fairly common in the higher incident in the women, as well as in the low socioeconomic groups in the low-income country. And that provides that there is indirect evidence that infectious burden could partly explain the disparity in the stroke risk among the high-income countries, middle-income countries, and the low-income countries. I'm going to select a few important things that is important to our region as well in the world. And we divided up into 4 major groups, the bacteria infection, virus infection, fungus, and the parasitic infection. So syphilis, the meningovascular syphilis, everybody knows that it is caused by the Treponema pallidum. And the CNS involvement is referred to as a neurosyphilis. And the neurosyphilis modern day is usually seen in the patient with the HIV infection. Cerebral infection is usually occur in up to 15% of the neurosyphilis cases, typically between the 5 to 10 years after the initial infection. Individuals with stroke caused by the neurosyphilis tend to produce a prodromal symptom such as a headache, malaise, emotional liability, personality, and behavior changes anywhere from the months to year before they actually had developed the stroke. So neurosyphilis should be considered in any young adult patient without any traditional risk factor for stroke, particularly if the stroke is recurrent and also involving in the large artery, such as the middle cerebral artery distribution. So proposed pathogenic mechanism of the syphilis-related stroke is due to be arthritis, direct invasion of the arterial wall, and the endotheliopathy. Next is the tuberculosis. Tuberculosis involving the central nervous system remains a serious public health problem much of the developing world. It is a leading cause of death by the infectious agent, and the 25% of the world population is afflicted by the Mycobacterium tuberculosis. Stroke can occur in the tuberculous meningitis up to 60%. Either the primary infection or the late reactivation of the tuberculosis can lead to deposition of the tubercles in the meninges, brain, and the skull. Ischemic stroke also being described in the tuberculous patient without central nervous system involvement. So proposed pathogenic mechanisms include the enhanced platelet aggregations, prothrombotic state, and arthritis, and the hypercoagulable state. This is the drawing of the pathophysiology of the stroke by tuberculous meningitis. Stroke in the tuberculous meningitis commonly affect the tubercle region, that is the head of the cortic nucleus, anteromedial thalamus, and the anterior limb and the genu of the internal capsule. In the HIV patient, you can see in the subcortical white matter as well as in the brainstem areas. Stroke contribute the morbidity and the mortality of the tuberculosis, and the presence of the ischemic stroke is one of the independent predictor for the functional disability and the death in tuberculous patients. Especially it is true in the large infarction involving in the middle cerebral arteries. When you obtain the angiogram, tuberculous meningitis, you see the three characteristic triads. Those are narrowing of the supraclinial internal carotid arteries, widely spreading pericallosal artery or outwarding bowing of the thalamostriatal vein, and the delayed circulation in the middle cerebral artery with the skin collaterals and the early draining veins. Unfortunately, you only see in the less than 50% of the patient with the tuberculous meningitis with these clinical triad. Up to 57% could be a normal angiogram. And the guideline for the treatment of the CNS-related tuberculosis related stroke is to treat the infection, which is a 4-drug regimen for the first 2 months, followed by the 2-drug regimens for up to 10 months. This regimen could be tailored depending on the patient characteristic as well as the sensitivity of the organism to the drugs. So this is a pathology finding of the basal meningitis as well as the brain abscess and the tuberculosis-related stroke. And on the right-hand side, you can see the MR imaging study of the tuberculous meningitis-related stroke as well as MR angiogram. Next is the acute bacterial meningitis. Acute bacterial meningitis is one of the 10 most common infectious causes of the death worldwide, and they frequently cause neurological sequelae among the survivors. Most of them, up to 80%, are community acquired and caused by the streptococcal pneumonia and the Neisseria meningitidis. People over the age of 50 and the immunocompromised patient could have a Listeria monocytogen as a cause of the bacterial meningitis. The risk factor for acute bacterial meningitis include age over the 65 and the immunocompromised state, that is asplenic, hyposplenism, HIV infection, cancer, diabetes, alcoholism, and a chronic immunosuppressive state. Ischemic stroke complicate up to 25% of the cases of the acute bacterial meningitis, causing a substantial neurological morbidity associated with it. And the stroke rates depend on the specific antigen, such as in streptococcal pneumonia-related stroke rate is up to 36%, but it is less than 10% in the Neisseria meningitidis. Age and high sedimentation rates are independent risk factor for infarction. And when someone comes in with the acute bacterial meningitis and the stroke, only 9% could be a CT positive at the time of the initial admission, and surprisingly, up to 17% throughout the clinical course of the acute bacterial meningitis-related stroke. Infection could well develop weeks after the initial diagnosis of meningitis. Not only the arterial meningitis, there is always a chance of the venous meningitis, complicating the acute bacterial meningitis cases in the venous infection and complicated the acute bacterial meningitis in up to 5% of these patients. Proposed pathogenic mechanisms include enhanced platelet aggregation, acceleration of the atherosclerotic through the induction of the cytokine induced in response to the specific antigenic stimulus and the chronic inflammation due to multiple infection, which is also known as the infectious burden. So this is a cartoon of the acute bacterial meningitis, simplified cartoon of acute bacterial meningitis pathophysiologic mechanism. Intracranial hemorrhage is another complication due to the acute bacterial meningitis, and you can see it in the 1 to 3% with patients. They usually occur with the streptococcus pneumonia and the Staph aureus, as well as the Pseudomonas aeruginosus and the Listeria monocytogenes. Common locations include the intraparenchyma and the subarachnoid area, as well as there will be a chance for hemorrhagic transformation of the acute ischemic infarction. Microhemorrhages could be seen up to 13% of these cases. About 2/3 of the cases, hemorrhage is diagnosed later in the clinical course of the acute bacterial meningitis. So next, we move to the virus infection. So first of all, the varicella zoster. Everybody almost have a chicken pox. A chicken pox related latent virus that located in the neurons, and that this is reactivated at some time. 95% of the adult population have the latent varicella zoster, which is from the chicken pox. Usually happen in the older age group in immunosuppressant. These are the two major risk factors for varicella zoster virus reactivation. Primary infection, either the primary infection, which is the varicella zoster, or shingle, which is this reactivation of the zoster virus, can cause a small or the large vessel vasculopathy or the vasculitis with the potential for the cause of the cerebral infarction. History of rash, either the zoster rash or the varicella chickenpox rash, is found in up to 2/3 of the patient with the herpes zoster virus vasculopathy. Rash and stroke can occur at the same time, or it may be at the average time for the development of the rash to stroke is approximately about 4 months. And especially the risk of stroke is high in the herpes zoster ophthalmicus and the trigeminal nerve distribution area involved. The absence of rash does not exclude the diagnosis of zoster virus vasculopathy in the appropriate clinical setting. Brain MRI may show the lesion in the gray and white matter junction, as well as the deeper structures in the brain, like a brain basal ganglia, internal capsule, or the deeper part of the cerebral cortex. MR imaging study of the CT angiogram, MR angiogram show the beating of the areas of the narrowing and the post-stenotic dilatation, aneurysm, and hemorrhage can be seen. Proposed pathogenic mechanisms include the arthritis or the non-inflammatory vasculopathy, and as well as the direct invasion of the arterial wall or the endotheliopathy is a consideration. This is a simplified form of the pathogenic mechanism of the varicella zoster virus. On the right-hand side, you can see the MR imaging study as well as an MR angiogram of the varicella zoster virus-related stroke. There is no large control study to guide the optimum treatment of the varicella zoster virus vasculopathy. Empiric intravenous acyclovir therapy, dosage of the 10 mg per kilogram body weight every 8 hours up to 14 to 21 days is recommended. There's no role of the corticosteroid therapy. Vaccination against the varicella zoster virus decrease the incidence of zoster and reduce the stroke risk and is highly recommended in the high-risk patient group, such as the older age group and the immunosuppressive patient. Other herpes virus group that they can cause the stroke is a CMV virus, cytomegalovirus, which increase the hemorrhagic stroke and the 3 times increase the ischemic stroke in the immunocompromised patients. Up to date, there is no evidence that suggested the herpes simplex virus play the direct role in the pathogenesis of the ischemic stroke. Next is the HIV infection. HIV is a significant of a crippling disease worldwide, and since it is found in 1980s, the increased risk of stroke is already noted. With the approach of the highly activated ART therapy, HIV disease become a chronic and a manageable stroke infection rather than the fatal one in the past. Stroke risk is higher in the HIV patient, approximately about 1.5 times higher. Majority of the HIV patient do have a traditional stroke risk factor, that is a smoking, diabetes, hypertension, hyperlipidemia, and the cardiovascular disease. Highly activated ART therapy can predispose the stroke patient to the metabolic syndrome, opportunistic infection, and the vasculopathy. Recently, 2 US studies reported that even after the adjustment of the traditional risk factors, HIV infection is an independent predictor for the stroke. Proposed pathogenic mechanisms include non-inflammatory vasculopathy, susceptibility to the opportunistic infection, and the possible direct invasion of the arterial wall and the endotheliopathy. Etiology of stroke can vary based on the type of the stroke. In the ischemic stroke, embolic etiology, thrombotic etiology, hypercoagulable state, and the hyperviscosity syndrome maybe play the role. Factor VIII deficiency of the hemophilia, thrombocytopenia, intracranial malignancy and the infection, rupture myocardic aneurysm, and the amphetamine and the cocaine vasculopathy may cause a hemorrhagic type of stroke in these HIV patients. Increased stroke risk in the patient with a high viral load and the lower CD4 counts. HIV also increased the hemorrhagic stroke, especially in the woman and the younger patient. Incidence of ischemic stroke is 5.27 per 1,000 HIV-infected patients compared to the 3.75 in non-infected person. HIV can directly invade the central nervous system as early as 8 days after the systemic infection. Pathophysiologically, again, it is a non-atherosclerotic vasculopathy, intima hyperplasia leading to the stenosis and the thinning of the media causing the aneurysm dilatation and the vasculitis. The relationship between the highly activated ART therapy and the stroke risk is unclear, but there is a proven that some of the medicines, such as a protease inhibitor, can increase the cerebrovascular event by twofold. In HIV and HIV patient, immunosuppression can cause the opportunistic infection with the increased risk of the cerebrovascular incident. Next is the COVID-19. COVID-19 is caused by a severe acute respiratory syndrome like coronavirus, SARS-CoV-2. And based on the knowledge, the incidence of cerebrovascular disease is approximately about 1.4% in the COVID-19 patient. Compared to the stroke without COVID-19, patients with the COVID-19 do have younger age and suffer the severe ischemic stroke throughout the large artery occlusion. Highest recorded stroke is seen in the Asian population as well as in the critically ill patients. Severity of the disease depending on corresponding with the significant risk point for the stroke among all the current study. Among the COVID-19, cardioembolism and the paradoxical embolism also should be considered due to involvement of the cardiac issue. Proposed pathogenic mechanisms include the hypercoagulable state, endotheliopathy, hyperinflammation, myocarditis, arrhythmia, and the complication from the critical illness. Here's a drawing of the proposed pathogenic mechanism that include the hypercoagulable state, vasculitis or the endotheliitis or the endothelial dysfunctions or the cardioembolism or the cardiac dysfunctions. Other viruses that are prone to have a stroke include the cytomegalovirus, parvovirus B19, hepatitis C, West Nile virus, and the enterovirus. Next, we're going to the fungal infection. Fortunately, fungal infections are very rare involved in the central nervous system, but once it's happened, it could be devastating. All three forms of fungus, that is the yeast, mold, and the dimorphous fungal, can cause central nervous system involvement and causing the stroke. Possible mechanisms include the vasculopathy, venous outflow obstructions, and the arthritis of the small vessels. Molds can have a direct invaded blood vessel wall, causing the arthritis and the myocardic aneurysm. Among them, I'm going to highlight the aspergillosis. Aspergillus fumigatus is one of the human pathogens mole associated with the stroke. Aspergillosis of the central nervous system, which we call like an invasive aspergillosis, occur up to 50% of the cases and may result from the disseminated systemic infection or from the direct invasion of the sinuses. It commonly seen in the immunocompromised patient. Hematogenous spread from the septic emboli from the peripheral sources can cause either the hemorrhagic stroke or the ischemic stroke with or without myocardic aneurysm or the arthritis. Focal deficit is seen in the 65% of these patients. Proposed pathogenic mechanisms include the arthritis and the infectious vasculopathy. Even though it is a rare, myocardic aneurysm is a very rare, but it is uniformly fatal. Infarction is a very territorial, located in the gray and white matter junctions and involved in the basal ganglia. Neuroimaging studies show the multiple hemorrhagic and the ischemic lesions in the thalamus, basal ganglia, corpus callosum with a very amount of edema. Here is a MR imaging study of the invasive aspergillosis. Other fungi, those could cause stroke include the Cryptococcus, Candida species, mucormycosis, rostrum leaf spot, histoplasmosis, coccidiomycosis, rose gardener disease, and the penicillium species. Next is a parasitic infection. Among them, the cerebral malaria is important on our region because there are about 400 to 500 million causes of malaria around the world, and the 30% of them are in Asia. It could be responsible for up to 10% of the stroke in the endemic regions. Among the malaria, Plasmodium falciparum is causing the cerebral malaria, has a 20% mortality rate, usually affect the children in the endemic area. The precise mechanism is unknown. There are two different clinical presentations between the children and the adult. Children can present with develop the coma very rapidly, and they followed by the cluster of seizures. In the adults, coma develop very gradually, and the seizures are left frequently. EEG may show generalized tonic-clonic seizure in natures with a focal origin. Proposed pathogenic mechanisms include occlusion of the cerebral arteries by the infective erythrocytes. Here's a map of the red areas in the wall map show the endemic area of the malaria. And our region, most of our region is included in there. And that this is a pathogenic mechanism of the cerebral malaria and the related stroke. Next is neuroschistosomiasis. It is caused by the schistosoma, the blood flukes, and the three species in our region is the Japonicum, Mekongii, and the malariensis. Usually happen in the acute or the subchronic stage of this schistosoma eggs, and the eggs usually reach through the CNS, through the retrograde blood flow, through the venous plexus. During the chronic state of infection, intracranial hemorrhage can be seen, especially with the Japonicum species, and then the other species, because the eggs of them, that species is much smaller.
We have 2 minutes.
And cerebral ganthosomiasis is a relatively rare, another tropical disease, and the cause by human is an accidental host. It's a diagnosis of suspicion, and you can see that. Before I conclude that, I would like to propose I would like to explain to the general principle of treatment. This is the infection, it's to treat the infection and to treat the stroke according to the guideline. Mortality rate may be higher in these patients. The role of oral or intravenous steroids along with the antibiotic infection is in the stroke. These patients is unclear. Antiplase could be approved for the thrombolytic treatment for acute stroke, but infection is not exactly a contraindication, but recommended for treatment cannot be made as a guideline because of the insufficient clinical data. Anticoagulation can be used in the appropriate setting, as well as an antiplatelet can be used. So, infectious, to finalize that, final thoughts are infectious causes of the stroke are insufficiently acknowledged, and they should be considered in the both pediatrics and the young patient without any risk factors for immunocompromised condition. high degree of suspicion is required. And most of the data are coming from the high-income country, and that we have a low-income data from the low-income country is a very spare. So understanding of the true association between the infectious pathogens and the stroke will be especially important to avoid the causal conclusion. Thank you very much.
Thank you very much.